In this video, I'm going to go over all of the bleeding disorders for step 1 in the simplest, clearest way that I know how, using the best mnemonics that I've found, so that you can learn this content as quickly and easily as possible. If this is helpful, consider liking and subscribing and I'll make more videos. Here we go. There's ITP, TTP, HUS, and DIC. I've got mnemonics for all of them. It'll be super simple. I hated learning this myself the first time. I want to make this easy for you. So ITP. For ITP, I just want you to think idiopathic. You can even think IDK, because you're going to look at the labs and all you're going to see is an increased bleeding time. Everything else, including PT and PTT, is going to be normal. So remember the I for idiopathic? I don't know what's wrong. It looks super normal. Now, this often follows a recent infection, and you are going to look out for petechia, purpura, and epistaxis, like nosebleeds. So USMLE loves to show normal PT, PTT, and then like an isolated platelet drop, that's it, with increased bleeding time. Idiopathic, I don't know. Everything seems normal, just a recent infection. Here are your most high yield things to know. Boom, no schistocytes. Normal PT, normal PTT. Viral illnesses in children, autoimmune diseases in adults. That's all you need to know for step 1. If you're preparing for step 2, treatments, steroids, IVIG, and refractory to splenectomy, and TPO agonists. That's only for step 2 though. But for step 1, all you need to know, ITP, boom, done. We're fourth away there, here we go. TTP. TTP, remember, the terrible pentad. Also, connect this T to this T here to remind you that it's a deficiency in Adams TS13. Why is this helpful? Well, on test day, you're going to see answer choices, and one of them is going to have this T in it, and you'll think, oh, TTP is connected with this T in Adams TS13, and that'll really help you get the point right. In your head, connect this with von Willebrand factor, because Adam TS13 deficiency can't cleave the ultra-large von Willebrand factor multimers. So let's pretend we got a cell here, and here are our von Willebrand factor multimers. They're like little towers that are standing up here. The red blood cell is going to pass through, and it's going to get cut. Oof, ouch. Look at that. That's a schistocyte. So unlike ITP, over here, we have schistiocytes. Because these unchecked von Willebrand factor is going to hurt these red blood cells. They're cutting them up, so now they're schistiocytes. They're getting shredded, not the good kind. Okay, so what do you see? Increased bleeding time. And here is the terrible pentad. Are you ready? Thrombocytopenia, anemia, fever, neuro, renal dysfunction. The most important one, if you can't remember all of those, which I recommend you should, one of those things you just have to clock it in there, but is fever. I'll tell you why in a second. But basically, no fever or neuro. If you don't have a fever or neuro, those are highly specific for TTP, then you might be looking at HUS. But before we move on, I know you're super excited. I know you're like, oh, what's HUS? Just wait a second. So our key features are the terrible pentad. The terrible pentad. Thrombocytopenia, renal failure, neuro, fever, schistiocytes. Remember the T, because Adam TS? You have normal PT and PTT. Why? Because your clotting factors are fine. Your clotting is fine, you're just shearing these guys up because of these von Willebrand factor guys. That's all for step 1. For you guys preparing for step 2, plasmapheresis, steroids, do not give platelets. That's the treatment. Okay, I know you're excited for this one, HUS. Remember what I said before, no fever or neuro, and you have schistiocytes? Ooh, maybe it's HUS, because you don't have the terrible pentad. Instead, we have hemolysis, uremia, stomach virus, HUS, because those are the most important things to think about. So imagine like a kid eating like an uncooked burger. This is toxin mediated. It's from the Shiga-like toxin. Remember the S for Shiga-like. I'm trying to explain this in the simplest way so you can memorize this easily. S for Shiga-like. If you like my approach, please consider liking and subscribing. Enough of that. E. coli. Okay, it's associated with E. coli, and you have to remember these letters and numbers. 0157H7. Why? That's like the phone number of Shigella. I'll give you a hint though. On test day, you're going to remember it's like, oh, it has like an O and an H in it. It's pretty much all you need to know. Just know that Shigella has a little phone number, and you'll see that string and you'll be like, oh, okay, that's totally Shigella. And because of this S, you'll think Shigella S, HUS. That's one of the nets I'm giving you. I'll give you a couple more fallbacks so that you'll ace this on test day. Essentially think of HUS as TTP, but for the kidney. Why? Because it has a similar triad. It's not the terrible pentad, because it doesn't have fever and neuro, but it surely has 3 of the same things. Thrombocytopenia, low platelets. It also has your schistiocytes, and it has your increased bleeding time. But this is kidney specific, so creatinine. Elevated creatinine is basically a way of saying, hey, we got kidney problems. Anytime on step 1, step 2, you see creatinine elevated, kidney problem. Very important too that you see this bloody diarrhea. That's the prodrome. Super important there. Because they'll throw that in with a bunch of GI bugs too, and you'll have to know it's E. coli, the Shiga-like form. So, you have hemolysis, because of your schistiocytes, you got uremia, and you got a stomach bug, HUS. Okay, why did you put the same exact smear here? Well, I put that because I wish somebody would have told me this earlier in my medical education. Anytime you see schistocytes, you're going to get like similar imaging, and you have to distinguish between them based on like weird factors that I've told you. And so on test day, you're going to see a lab, you're going to see schistocytes, and you're going to think, oh, I should have known this. But the thing is, you're fine. You're chilling. Nobody looks at the schistocyte and automatically knows which type it is. You have to look at these special details to figure out which one it is. Respiratory infection, or a recent infection, or idiopathic and doesn't have schistocytes, then you're looking at like ITP. Boom, got it. But if you see schistocytes, then you got to be like, okay, is there fever? Is there neuro? Okay, TTP. Oh, is it like kidney creatinine elevated? If it is, then it's HUS. Oh, is there D-dimer elevation? It is. If so, then DIC. And I know you're excited about that one. I'll tell you in a second. And that's why I put a little bit of like a podocyte image here, because this is like kidney stuff. You should look at this and be like, ooh, kidney. Ooh, HUS. Right? Because one of the key labs is you have that elevated creatinine. So the kidney gets hit. And here you have a normal PT and PTT as well. So here are your key symptoms after bloody diarrhea, HUS. Okay, that's all for step 1. If you're studying for step 2, treatment, supportive, IV fluids, dialysis, avoid antibiotics, and anti-motility drugs. Okay, last one. Wasn't this easy? Hopefully it was. If it was, like and subscribe. Because if I see that this video does well, I'll just keep making more, and you'll get better and better content. DIC. Instead of thinking DIC, I want you to think, damn, I'm clotting. Why? Because you have systemic triggers like sepsis or trauma or like a malignancy that dumps tissue factor in the blood. And you get consumptive coagulopathy. Ooh, big scary word. That just means you're forming microthrombi everywhere. And so it's just going to be chewing through all these schistocytes, just chewing them up. You got microthrombi everywhere. It's like that Buzz meme. You know, the Buzz Lightyear one, when he's got his arm around Woody? Microthrombi everywhere. So this one is special, guys, because look at this. The PT and PTT is elevated. I color-coded them with the C, because the C is, you think, coagulation, because it's disseminated intravascular coagulation. Damn, I'm clotting. So this C thing right here, that relates to these signs. Increased platelets, they're trying to do their thing. The PT and PTT is elevated. Why? Because these factors are gone, dude. They've been used up. And so you can't clot, and the fibrinogen is used up. And the D-dimer is super unique. So remember, D for disseminated is D for D-dimer. If that's elevated, think DIC. Huge tip, especially if you're going through UWorld, preparing for step 1. If there's diffuse oozing, bleeding around the IV lines, or the gums, or surgical wounds, DIC. Oozing, DIC. Okay, once again, I did these same images because I want you to know that you see a schistocyte and you think, oh, I should have known better. No, you're still doing fine. There are 3 different types you still got to parse through. If it's an elevated D-dimer, it's DIC. Here's another schistocyte, little looking guy, so you don't just think they all have to look like this pale image background. So here are your key features. DIC, widespread clotting, elevated PT and PTT, because they're all used up. Everything is used up. So the D-dimer is used up. Remember the D associated with the D here, much the same way the S is associated with the Shiga. That'll give you some free points there, fallback. And also you got your schistocytes present, caused by sepsis, trauma, malignancy, obstetric complications. Okay, that's it for step 1. Step 2, you treat the underlying cause, give some blood products, FFP, precipitate. I've actually seen a practice question on that for step 1, and give them platelets effectively bleeding. That wasn't so hard, was it? But this is so high yield. And honestly, this is like, if your curriculum was anything like my curriculum in medical school, this is a huge portion of your hem-onc class, right? These are your bleeding disorders. So for you freaks out there who don't like nice fun visuals, here's your little quick comparison table. Notice how DIC is so different with its PT and PTTs. Notice how it's got a weird fibrinogen level that's been exhausted. Notice how all of these guys have schistocytes except for this guy. Why? I don't know. That was our mnemonic, really. He's idiopathic, so I don't know. Notice how HUS has a severe renal problem and also your neuro problem. TTP is the terrible pentad. Oh, excuse me. I said HUS has the neuro, but that is not the case. It is rare for HUS. It is the TTP that has the neuro. See, the mnemonic helped me just recall that right now. TTP, the terrible pentad, why you do have the neuro and you also have the fever. Other than that, they're pretty similar to HUS and TTP. See, these little mnemonics, they're like fallback mechanisms. They just help you. They make you more capable of answering these questions correctly, because if you have a quick mental slip, you're like, wait, that didn't make sense because this is the terrible pentad. And so of course it's going to have more factors like a neuro factor or a fever factor. And that's what distinguishes it. It's the terrible pentad. So it's got all of those symptoms. My goal here is really to make your guys' life easier. So really quickly, final recap, and then we're done. ITP, I don't know, seems idiopathic to me. Pretty much nothing wrong. Just give them some steroids. TTP, the terrible pentad, so you have neuro symptoms and also fever. Remember this T, you got double T's, so you think of Adam TS. So I'll write Adam TS there for the mechanism. HUS for Shiga toxin. Severe renal problems, because it really is like TTP, but it's for the kidney. DIC. Damn, I'm coagulating. You've just made so many platelets, exhausted the cascade, used up your fibrinogen. Treat that cause. And these last 3 have histiocytes. That's the best way I know how to teach this content. But look, you've mastered it all. And there's a lot of content we just covered. This is my 3rd video in the series. I'll make more if you guys like this video and subscribe. Good luck studying for step 1. Just a last message here. Dedicated period, step 1, medical school generally. It is a long grind. So take care of yourselves out there. Do something fun. Take your dog for a walk. Get some sunshine. Reach out and make some new friends. You're sacrificing your 20s so that you can be well informed and help out patients. It's very admirable, but take some time for yourself too. If you're feeling a little bit down, remember that no thought is final. Remember that every single day is a new chance to be somebody entirely different. Just wanted to say, be nice to yourself. You're doing great things. You're learning this content. It's not fun for anybody, but we're all out here trying to make it as tolerable and as fun as possible. Anyways, hopefully this has been helpful. If it was, consider liking and subscribing, and we'll see you in the next video. Peace out.